the biomarkers that are frequently used are the creatinine and the proteinuria measurement and hematuria measurement. And these are done usually on routine basis every 3 to 6 months in patients who have systemic lupus erythematosus. Utilizing these measurements will allow the clinician to detect early kidney involvement and will allow early referral, and this early referral will lead to better outcome as far as therapy efficacy. So for the diagnosis of lupus nephritis, the approach for the diagnosis of lupus nephritis might be different depending on the presentation of the patient. So some patients are having routine workup as part of screening for systemic lupus erythematosus, where they have a regular checkup for their creatinine and urinalysis for proteinuria. And these patients are referred to nephrology evaluation early on before they develop any symptoms. In this situation, usually we do recommend a kidney biopsy for these patients to establish diagnosis. Other patients are referred or present to the emergency room with symptoms of renal involvement, and the main symptoms is edema. It could be lower extremity edema or periorbital edema. In these situations, also we do recommend a kidney biopsy to establish diagnosis, but based on that presentation, the workup might be a little bit more extensive because they may not have an established diagnosis of systemic lupus erythematosus before the lupus nephritis is diagnosed. Kidney biopsy is the most essential part of diagnosis for lupus nephritis. Doing a kidney biopsy has both diagnostic value and prognostic value. So when it comes to patients who have SLE and present with some form of kidney involvement, we try to do a kidney biopsy in most of these patients. In some situation, if patient is an anticoagulation chronically, where we cannot stop the anticoagulation, or if the patient refuses to do a kidney biopsy, we do move into empirical treatment for lupus nephritis, but these are usually rare instances. In general, I approach for any patient who have SLE and proteinuria above 500 milligrams per day, I do recommend a kidney biopsy. If I see active red urine sediment with hematuria and proteinuria, I do recommend a kidney biopsy. Or if I see worsening creatinine, I do recommend a kidney biopsy in these patients. So the current guidelines as far as the treatment for lupus nephritis do utilize 3 different regimens for induction. The first regimen includes high-dose corticosteroid, PO plus mycophenolate mofetil. And the other induction therapy is what we call Lupus protocol, which is cyclophosphamide 500 milligram every 2 weeks for 6 doses. And the third regimen is cyclophosphamide, what we call NIH protocol, which includes prednisone plus cyclophosphamide 500 to 1,000 milligram per meter square every month for 6 doses. All of these regimens do utilize high-dose steroid, and this steroid usually is tapered over 6 months, and most of the patients are kept on a very low-dose steroid at 6 months. As far as the mycophenolate mofetil, it's given usually at a dose of 1,500 milligram twice daily. In some specific ethnicity, mainly Asian, we can utilize lower dose around 1,000 milligram twice daily. For the Lupus and NIH protocol, since it does utilize cyclophosphamide, these patients usually are getting IV infusion of cyclophosphamide, and they're having frequent checkup of their CBC and frequent checkup for any kind of infection to avoid any side effects from these treatments. With the approval of the 2 newer medication, voclosporin and belimumab, the induction therapy regimen have changed a little bit, especially in a subgroup of patients where I feel these 2 medications might have additional benefit. So in some subgroup of patients and selected patients, I've been prescribing prednisone, lower dose of prednisone with mycophenolate mofetil plus voclosporin or belimumab or other calcineurin inhibitor, depending on the patient clinical presentation and some other criteria that are specific for each patient. As far as the maintenance therapy that I use is usually CellCept, which is mycophenolate mofetil that I taper over almost at least for 3 years. They will receive the CellCept therapy. taper if they have complete remission. If they do not have complete remission, it's a lifelong immunosuppression therapy. An alternative to mycophenolate mofetil is azathioprine maintenance therapy. So as far as response to therapy, these patients are frequently monitored by serial checkup of their basic metabolic panel and checking their creatinine, checking their albumin, and checking their proteinuria by checking either urine protein creatinine ratio or 24-hour urine protein checkup. In other situations, we do check also complement level, anti-double-strand DNA to check also for the lupus activity in general in these patients. My approach is to, during the induction phase, is to do these biomarker, the creatinine and the proteinuria on a monthly basis, at least, if not more frequently, to assess if the patient is worsening. Usually what we see is that initially during the induction phase, the patient does take a long time, up to 2 to 3 months to have an improvement. So our initial goal is to monitor for any worsening that will require change of therapy. And usually we do hold the same therapy for at least 6 months before switching therapy, unless we have acute worsening early on.